Resident Assessment. Appendix PP, Regulation Section 483.20, tags F635 through F646. Begin reading. Tag F635. Section 483.20, 0A Admission Orders. At the time each resident is admitted, the facility must have physician orders for the resident's immediate care. Intent Section 483.20A. To ensure each resident receives necessary care and services upon admission. Guidance Section 483.20A. Physician orders for immediate care are those written and / or verbal orders facility staff need to provide essential care to the resident, consistent with the resident's mental and physical status. Upon admission to the facility, these orders should, at a minimum, include dietary, medications, if necessary, and routine care to maintain or improve the resident's functional abilities until staff can conduct a comprehensive assessment and develop an interdisciplinary care plan. Tag F636. Section 483.20, Resident Assessment. The facility must conduct initially and periodically a comprehensive, accurate, standardized, reproducible assessment of each resident's functional capacity. Section 483.20, 0B Comprehensive Assessments. Section 483.20, 0B1 Resident Assessment Instrument. A facility must make a comprehensive assessment of a resident's needs, strengths, goals, life history, and preferences using the Resident Assessment Instrument RI specified by CMS. The assessment must include at least the following: I. Identification and demographic information. Roman 2. Customary routine. Roman 3. Cognitive patterns. Roman 4. Communication. V. Vision. Roman 6. Mood and behavior patterns. Roman 7. Psychological well-being. Roman 8. Physical functioning and structural problems. Roman 9. Continence. X. Disease diagnosis and health conditions. Roman 11. Dental and nutritional status. Roman 12. Skin conditions. Roman 13. Activity pursuit. Roman 14. Medications. Roman 15. Special treatments and procedures. Roman 16. Discharge planning. Roman 17. Documentation of summary information regarding the additional assessment performed on the care areas triggered by the completion of the minimum data set. MDS. Roman 18. Documentation of participation in assessment. The assessment process must include direct observation and communication with the resident, as well as communication with licensed and non-licensed direct care staff members on all shifts. Section 483.20B2, when required, subject to the timeframes prescribed in Section 413.343B of this chapter. A facility must conduct a comprehensive assessment of a resident in accordance with the timeframes specified in paragraphs B2I through Roman 3 of this section. The timeframes prescribed in Section 413.343B of this chapter do not apply to cause I within 14 calendar days after admission, excluding readmissions in which there is no significant change in the resident's physical or mental condition. For purposes of this section, readmission means a return to the facility following a temporary absence for hospitalization or therapeutic leave. Asterisk. Roman 3 not less than once every 12 months. Intent Section 483.2, 0B12I and Roman 3. To ensure that the Resident Assessment Instrument RI is used in accordance with specified format and timeframes in conducting comprehensive assessments as part of an ongoing process, through which the facility identifies each resident's preferences and goals of care, functional and health status, strengths and needs, as well as offering guidance for further assessment once problems have been identified. Definitions, Section 483.2, 0B12I and Roman 3. Minimum data set. The minimum data set MDS is part of the U.S. federally mandated process for clinical assessment of all residents in Medicare or Medicaid-certified nursing homes. It is a core set of screening, clinical and functional status elements, including common definitions and coding categories, which forms the foundation of a comprehensive assessment. Care Area Assessment CA process is a process outlined in Chapter 4 of the MDS Manual, designed to assist the assessor to systematically interpret the information recorded on the MDS. Once a care area has been triggered, nursing home providers use current, evidence-based clinical resources to conduct an assessment of the potential problem and determine whether or not to care plan for it. The CAA process helps the clinician to focus on key issues identified during the assessment process so that decisions as to whether and how to intervene can be explored with the resident. This process has 3 components. Care area triggers, CATs, are specific resident responses for one or a combination of MDS elements. The triggers identify residents who have or are at risk for developing specific functional problems and require further assessment. Care Area Assessment, CAA, is the further investigation of triggered areas. 2. Determine if the care area triggers require interventions and care planning. CAA Summary Section, V of the MDS, provides a location for documentation of the care areas that have triggered from the MDS, the decisions made during the CAA process regarding whether or not to proceed to care planning, and the location and date of the CAA documentation. Comprehensive assessment includes the completion of the MDS as well as the CAA process, followed by the development and/or review of the comprehensive care plan. Comprehensive MDS assessments include admission, annual, significant change in status assessment, and significant correction to prior comprehensive assessment. Resident Assessment Instrument RAI consists of 3 basic components: the minimum data set MDS version 3.0, the Care Area Assessment CA process, and the RAI utilization guidelines. The utilization of these components of the RAI yields information about a resident's functional status, strengths, weaknesses, and preferences, as well as offering guidance on further assessment once problems have been identified. Utilization guidelines provide instructions for when and how to use the RAI. The utilization guidelines are also known as the Long-Term Care Facility Resident Assessment Instrument 3.0. User's Manual. Guidance Section 483.2, 0B12I and Roman 3. Each facility must use the RAI specified by CMS, which includes the MDS utilization guidelines and the CAAs to assess each resident. The facility is responsible for addressing all needs and strengths of residents, regardless of whether the issue is included in the MDS or CAAs. The scope of the RAI does not limit the facility's responsibility to assess and address all care needed by the resident. The information required in Section 483.2, 0B1I Roman 18 is incorporated into the MDS, which forms the core of the RAI process. Additional assessment information is also gathered using triggered care area assessments, CA, after the completion of the comprehensive MDS. The facility is expected to use resident observation and communication as the primary source of information when completing the RAI, in addition to record review, direct observation, and communication with the resident. The facility must use a variety of other sources, including Communication with licensed and non-licensed staff members on all shifts, and may include discussions with the resident's physician, the resident's representative, family members, or outside consultants. At a minimum, facilities are required to complete a comprehensive assessment of each resident. Within 14 calendar days after admission to the facility, when there is a significant change in the resident's status, and not less than once every 12 months while a resident. For the purpose of this guidance, not less than once every 12 months means within 366 days. For additional requirements regarding a significant change in status assessment, see Section 483.2, 0B2 Roman 2. If a comprehensive assessment was completed any time prior to a temporary absence for hospitalization or a leave of absence, and upon return to the facility, the resident does not meet the criteria for a significant change in status assessment, SCSA, as defined in Section 483.2, 0B2 Roman 2, A. Comprehensive assessment is not required. For example, a resident had a comprehensive assessment completed within 14 days of admission, 4 months later was hospitalized, then returned to the facility. Upon return to the facility, the resident's status does not meet the criteria for a SCSA, therefore a comprehensive assessment is not required. For additional information on assessment scheduling and completion requirements, see Chapter 2 of the Long-Term Care Facility Resident Assessment Instrument 3.0 User's Manual. Link to the LTCF RAI User's Manual. https://www.cms.gov/Medicare/Quality Initiatives Patient Assessment Instruments/Nursing Home Quality in its /MDS30 RAI Manual HTML. The facility must use the RAI process to develop a comprehensive care plan to provide the appropriate care and services for each resident, and to modify the care plan and care/services based on the resident's status. Probe Section 483.2, 0B12I and Roman 3. Did the facility complete a comprehensive assessment using the CMS-specified RAI process within the regulatory timeframes, i.e. within 14 days after admission, and at least annually for each resident in the sample? Is there evidence in the clinical record that the facility gathered and analyzed supplemental information based on the triggered CAAs prior to developing the comprehensive care plan? For reference, a list of CAAs is found in Section V of the MDS Care Area Assessment Summary. Is there evidence of resident and/or resident representative participation in the assessment process? Examples include participating in the resident interviews, providing information about preferences or discharge goals. Ask licensed and non-licensed direct care staff if they participate in the resident assessment process. Does the facility have a system in place to assure assessments are conducted in accordance with the specified timeframes for each resident? Tag F637. Section 483.2, 0B2 Roman 2, within 14 days after the facility determines, or should have determined, that there has been a significant change in the resident's physical or mental condition. 4. Purpose of this section: a significant change means a major decline or improvement in the resident's status that will not normally resolve itself without further intervention by staff or by implementing standard disease-related clinical interventions that has an impact on more than one area of the resident's health status and requires interdisciplinary review or revision of the care plan, or both. Intent Section 483.2, 0B2 Roman 2. To ensure that each resident who experiences a significant change in status is comprehensively assessed using the CMS-specified Resident Assessment Instrument RAI process. Definitions, Section 483.2, 0b2 Roman 2. Significant change is a major decline or improvement in a resident's status that one will not normally resolve itself without intervention by staff or by implementing standard disease-related clinical interventions. The decline is not considered self-limiting. Note, self-limiting is when the condition will normally resolve itself without further intervention or by staff implementing standard clinical interventions to resolve the condition. 2 impacts more than one area of the resident's health status, and 3 requires interdisciplinary review and or revision of the care plan. This does not change the facility's requirement to immediately consult with a resident's physician of changes as required under 42 CFR Section 483.10 I-14, F635. Significant change in status assessment, SCSA, is a comprehensive assessment that must be completed when the interdisciplinary team IT has determined that a resident meets the significant change guidelines for either major improvement or decline. Assessment reference date ARD is the specific endpoint for the look-back periods in the minimum data set MDS assessment process. This look-back period is also called the observation or assessment period. Guidance Section 483.2, 0b2 Roman 2. A SCSA including care area assessments CA must be completed within 14 days after a determination has been made that a significant change in the resident's status from baseline occurred. This may be determined by comparison of the resident's current status to the most recent comprehensive assessment and most recent quarterly assessment, and the resident's condition is not expected to return to baseline within 2 weeks. A SCSA is appropriate if there are either 2 or more MDS areas of decline or 2 or more MDS areas of improvement, or if the IDT determines that the resident would benefit from the SCSA assessment and subsequent care plan revision. The facility should document in the medical record when the determination is made that the resident meets the criteria for a significant change in status assessment. A significant change in status, MDS, is required when a resident enrolls in a hospice program, or a resident changes hospice providers and remains in the facility, or a resident receiving hospice services discontinues those services, or a resident experiences a consistent pattern of changes with either 2 or more areas of decline or 2 or more areas of improvement from baseline as indicated by comparison of the resident's current status to the most recent CMS-required MDS. Examples of decline include, but are not limited to, resident's decision-making ability has changed, presence of a resident mood item not previously reported by the resident or staff, and or an increase in the symptom frequency, e.g., increase in the number of areas where behavioral symptoms are coded as being present and or the frequency of a symptom. Increases for items in Section E behavior. Changes in frequency or severity of behavioral symptoms of dementia that indicate progression of the disease process since last assessment. Any decline in an ADL physical functioning area, at least one where a resident is newly coded as extensive assistance, total dependence, or activity did not occur since last assessment and does not reflect normal fluctuations in that individual's functioning. Resident's incontinence pattern changes, or there was placement of an indwelling catheter. Emergence of unplanned weight loss problem, 5% change in 30 days or 10% change in 180 days. Emergence of a new pressure ulcer at stage 2 or higher, a new unstageable pressure ulcer/injury, a new deep tissue injury or worsening in pressure ulcer status. Resident begins to use a restraint of any type when it was not used before. Emergence of a condition/disease in which a resident is judged to be unstable. Examples of improvement include, but are not limited to, any improvement in ADL physical functioning area, at least one where a resident is newly coded as independent, supervision, or limited assistance since last assessment and does not reflect normal fluctuations in that individual's functioning. Decrease in the number of areas where behavioral symptoms are coded as being present. And / or the frequency of a symptom decreases. Resident's decision-making ability improves. Resident's incontinence pattern improves. If there is only one change, the resident may still benefit from a SCSA as determined by the IDT or as initiated by the resident based on changes in the care plan. It is important to remember that each resident's situation is unique. The facility must document a rationale in the resident's medical record for completing a SCSA that does not meet the criteria for completion. The facility may not complete a SCSA until after a comprehensive admission assessment has been completed. A significant change in status, MDS, is considered timely when the RN assessment coordinator signs the MDS as complete at section Z0500B and V0200B2 by the 14th calendar day after the determination that a significant change has occurred. Determination date plus 14 calendar days. If a SCSA MDS is completed, the next annual assessment is not due until 366 days after the ARD of the significant change in status assessment. Note, for information on assessment scheduling for the MDS, see Chapter 2 of the Long-Term Care Facility Resident Assessment Instrument 3.0 User's Manual. Link to the LTCF RAI User's Manual, https://www.cms.gov/Medicare/Quality Initiatives Patient Assessment. Instrument/Nursing Home Quality, in its /MDS30 RAI Manual HTML. Circumstances when a change in resident status is not significant include, but are not limited to, short-term acute illness, such as a mild fever secondary to a cold from which the IDT expects the resident to fully recover. Well-established, predictable cyclical patterns of clinical signs and symptoms associated with previously diagnosed conditions, e.g., depressive symptoms in a resident previously diagnosed with bipolar disease would not precipitate a significant change assessment. Instances in which the resident continues to make steady progress under the current course of care, reassessment is required only when the condition has stabilized. Instances in which the resident has stabilized but is expected to be discharged in the immediate future, the facility has engaged in discharge planning with the resident and family, and a comprehensive reassessment is not necessary to facilitate discharge. Planning. Probes Section 483.2, 0B2 Roman 2. Did the facility identify, in a timely manner, those residents who experienced a significant change in status? Is there documentation in the medical record when the determination was made that the resident met the criteria for a significant change in status assessment? Did the facility reassess residents who had a significant change in status using the CMS specified RAI within 14 days after determining the change was significant? Tag F638. Section 483.2, 0C Quarterly Review Assessment. A facility must assess a resident using the quarterly review instrument specified by the state and approved by CMS not less frequently than once every 3 months. Intent Section 483.20C. To assure each resident is assessed using the standardized quarterly review assessment tool no less than once every 3 months between comprehensive assessments. Definitions, Section 483.20c. Quarterly review assessment is an ABRA 87 required, non-comprehensive assessment that must be completed at least every 92 days following the previous ABRA assessment of any type. It is used to track a resident's status between comprehensive assessments to ensure critical indicators of gradual change in a resident's status are monitored. As such, not all minimum data set MDS items appear on the quarterly assessment. Guidance Section 483.20c. At least every 92 days, the facility shall review each resident with respect to those MDS items specified in the CMS Quarterly Assessment, MDS. A quarterly assessment is considered timely if the assessment reference date ARD of the quarterly, MDS, is within 92 days ARD of most recent ABRA assessment plus 92 days after the ARD of the previous ABRA. Assessment quarterly, admission, annual significant change in status, significant correction to prior comprehensive or quarterly assessment and the MDS completion date, item Z0500B, must be no later than 14 days after the ARD plus 14 calendar days. If the resident has experienced a significant change in status, the next quarterly review is due no later than 3 months after the ARD of the significant change in status assessment. For information on assessment scheduling for the MDS, see Chapter 2 of the Long-Term Care Facility Resident Assessment Instrument 3.0 User's Manual. Link to the LTCF RAI User's Manual. https://www.cms.gov/Medicare/Quality Initiatives. Patient Assessment Instruments/Nursing Home Quality in its /MDS30 RAI Manual HTML. Note, the quarterly MDS does not require the completion of care area assessments. However, the resident's care plan must be reviewed and revised by the interdisciplinary team after each assessment, as required at Section 483.2, 1B2 Roman 3. Probes Section 483.20c. Does the facility assess residents using the CMS-specified quarterly review assessment? No. Less than once every 3 months, between comprehensive assessments. Is there evidence of resident and or resident representative participation in the assessment process? Examples include participating in the resident interviews and providing information about preferences or discharge goals. Tag F639. Section 483.20d Use. A facility must maintain all resident assessments completed within the previous 15 months in the resident's active record and use the results of the assessments to develop, review, and revise the resident's comprehensive care plan. Intent Section 483.20d. Facilities are required to maintain 15 months of assessment data in each resident's active clinical record. Guidance Section 483.20d. The requirement to maintain 15 months of data in the resident's active clinical record applies, regardless of form of storage, to all minimum data set MDS records, including the care area. Assessment cost summary, quarterly assessment records, identification information and entry, discharge and reentry tracking records, and MDS correction requests including signed attestation. MDS assessments must be kept in the resident's active clinical record for 15 months following the final completion date for all assessments and correction requests. Other assessment types require maintaining them in the resident's active clinical record for 15 months. Following the entry date for tracking records including re-entry, and the date of discharge or death for discharge and death in facility records. Facilities may maintain MDS data electronically regardless of whether the entire clinical record is maintained electronically and regardless of whether the facility has an electronic signature. Process in place. This is in accordance with state and local law, and when this is authorized by the Long-Term Care Facilities Policy. Facilities that maintain their MDS data electronically and do not utilize an electronic signature. Process must ensure that hard copies of the MDS assessment signature pages are maintained for every MDS assessment conducted in the resident's active clinical record for 15 months. This includes enough information to identify the resident and type and date of assessment linked with the particular assessment signature pages. The information, regardless of form of storage, i.e., hard copy or electronic, must be kept in a centralized location and must be readily and easily accessible. This information must be available to all professional staff members, including consultants who need to review the information in order to provide care to the resident. This information must also be made readily and easily accessible for review by the State Survey Agency and CMS. Resident-specific information must also be available to the individual resident. If there are concerns, please refer to F635. After the 15-month period, RAI information may be thinned from the clinical record and stored in the Medical Records Department, provided that it is easily retrievable if requested by clinical staff, the state agency, or CMS. Note, states may have more stringent requirements for this process. If there are concerns about how the results of the resident assessment are used to develop, review and revise the resident's comprehensive care plan, see Section 483.21b2 Roman 3, F657. Tag F640. Section 483.20F, Automated Data Processing Requirement. Section 483.20F1, Encoding Data. Within 7 days after a facility completes a residence assessment, a facility must encode the following information for each resident in the facility. I. Admission Assessment. Roman 2, Annual Assessment Updates. Roman 3, Significant Change in Status Assessments. Roman 4, Quarterly Review Assessments. V. A subset of items upon a resident's transfer, re-entry, discharge, and death. Roman 6, Background, face sheet information, if there is no admission assessment. Section 483.20F2, Transmitting Data. Within 7 days after a facility completes a residence assessment, a facility must be capable of transmitting to the CMS system information for each resident contained in the MDS in a format that conforms to standard record layouts and data dictionaries, and that passes standardized edits defined by CMS and the state. Section 483.20F3, Transmittal Requirements. Within 14 days after a facility completes a residence assessment, a facility must electronically transmit encoded, accurate, and complete MDS data to the CMS system, including the following: I. Admission Assessment. Roman 2, Annual Assessment. Roman 3, Significant Change in Status Assessment. Roman 4, Significant Correction of Prior Full Assessment. V. Significant Correction of Prior Quarterly Assessment. Roman 6, Quarterly Review. Roman 7, A subset of items upon a resident's transfer, re-entry, discharge, and death. Roman 8, Background, face sheet information, for an initial transmission of MDS data on resident that does not have an admission assessment. Section 483.20F4, Data Format. The facility must transmit data in the format specified by CMS, or, for a state which has an alternate RAI approved by CMS, in the format specified by the state and approved by CMS. Intent Section 483.2, 0F1 to 4. To ensure that facilities have provided resident-specific information for payment and quality. Measure purposes. To enable a facility to better monitor each resident's decline and progress over time. Computer. Aided data analysis facilitates a more efficient, comprehensive, and sophisticated review of health. Data. Definitions, Section 483.2, 0F1 to 4. Accurate means that the encoded MDS data matches the MDS form in the clinical record. Also refer to guidance regarding accuracy at Section 483.20G, and the information accurately reflects the resident's status as of the assessment reference date ARD. Background face sheet information refers to the MDS entry tracking record. Capable of transmitting means that the facility has encoded and edited according to CMS. Specifications. The record accurately reflects the resident's overall clinical status as of the assessment reference date, and the record is ready for transmission. Complete means that all items required according to the record type and in accordance with CMS record specifications and state-required edits are in effect at the time the record is completed. Discharge subset of items refers to the MDS discharge assessment. Encoding means entering information into the facility MDS software in the computer. Passing standard edits means that the encoded responses to MDS items are consistent and within range in accordance with CMS-specified standards. In general, inconsistent responses are either not plausible or ignore a skip pattern on the MDS. An example of inconsistency would be if one or more MDS items on a list were checked as present, and none of the above response was also checked for the same list. Out-of-range responses are invalid. Responses, such as using a response code of 2 for an MDS item for which the valid responses are 0 or 1. Transmitted means electronically transmitting to the Quality Improvement Evaluation System KAI's assessment submission and processing ASAP system, an MDS record that passes CMS standard edits and is accepted into the system within 14 days of the final completion date or event date in the case of entry and death in facility situations of the record. Transmitting data refers to electronically sending encoded MDS information from the facility to the KAI's ASAP system. Guidance Section 483.2, 0F1 to 4. Facilities are required to encode MDS data for each resident in the facility. Facilities are required to electronically transmit MDS data to the CMS system for each resident in the facility. The CMS system for MDS data is named the KAI's ASAP system. Facilities are responsible to edit the encoded MDS data to ensure that it meets the standard edit specifications. For Section 483.20 F1V, the subset of items required upon a resident's entry, transfer, discharge, and death are contained in the entry and death in facility tracking records and discharge assessments. Refer to Chapter 2 of the Long-Term Care Resident Assessment Instrument. User's Manual for further information about these records. All nursing homes must computerize MDS information. The facility must edit MDS information using standard CMS-specified edits, revise the information to conform to the edits, and to be accurate, and be capable of transmitting that data to the KAI's ASAP system within 7 days. For a comprehensive assessment admission, annual, significant change in status, and significant correction to prior comprehensive, encoding must occur within 7 days. After the care plan completion date V0200 C2 plus 7 days. For a quarterly, significant correction to prior quarterly, discharge, or PPS. Assessment. Encoding must occur within 7 days after the MDS completion date. Z0500B plus 7 days. For a tracking record, encoding should occur within 7 days of the event date, A1600. Plus 7 days for entry records, and A2000 plus 7 days for death in facility records. Submission must be according to state and federal timeframes. Therefore, the facility must encode the MDS and CAA's summary, where applicable in machine-readable format, and edit the MDS and CAA summary, where applicable according to edits specified by CMS. Within the 7-day time period specified above for editing, the facility must revise any information on the encoded MDS and CAA summary, if applicable, that does not pass CMS-specified edits, revise any otherwise inaccurate information, and make the information ready for submission. The MDS vendor software used at the facility should have an automated editing process that alerts the user to entries in an MDS record that do not conform to the CMS-specified edits, and that prompts the facility to complete revisions within the 7-day editing and revision period. After editing and revision, MDS information and CAA summary information, if applicable, must always accurately reflect the resident's overall clinical status as of the original ARD for an assessment or the original event date for a discharge or entry. Electronically submit MDS information to the CAI's ASAP system within 14 days. Assessment transmission. Comprehensive assessments must be transmitted electronically within 14 days of the care plan completion date, V0200C2 plus 14 days. All other assessments must be submitted within 14 days of the MDS completion date, Z0500B plus 14 days. Tracking information transmission. For entry and death in facility tracking records, information must be transmitted within 14 days of the event date, A1600 plus 14 days for entry records, and A2000 plus 14 days for death in facility records. Only CMS-required MDS assessments, e.g., ABRA and Medicare Part, a PPS, are permitted to be transmitted into the CAI's ASAP system. Assessments completed to meet third-party payer, i.e. private insurance or managed care requirements, cannot be transmitted to CMS. ABRA. MDS assessments completed anytime a facility is not certified to participate in Medicare/Medicaid cannot be transmitted. Procedures Section 483.2, 0F1 to 4. If the surveyor suspects the facility is not encoding and submitting assessments as required, the surveyor should review the facility's MDS 3.0 NH final validation report to verify assessment. Submission into the CAI's ASAP system. Tag F641. Section 483.2, 0G accuracy of assessments. The assessment must accurately reflect the resident's status. Intent Section 483.20G. To assure that each resident receives an accurate assessment, reflective of the resident's status at the time of the assessment, by staff qualified to assess relevant care areas and are knowledgeable about the resident's status, needs, strengths, and areas of decline. Guidance Section 483.20G. Accuracy of assessment means that the appropriate, qualified health professionals correctly document the resident's medical, functional, and psychosocial problems and identify resident strengths to maintain or improve medical status, functional abilities, and psychosocial status. Using the appropriate resident assessment instrument, RI, i.e. comprehensive, quarterly. Significant change in status. Facilities are responsible for ensuring that all participants in the assessment process have the requisite knowledge, to complete an accurate assessment. The determination of appropriate participation of health professionals must be based on the physical, mental, and psychosocial condition of each resident. This includes an appropriate level of involvement of physicians, nurses, rehabilitation therapists, activities professionals, medical, social workers, dietitians, and other professionals, such as developmental disabilities specialists. In assessing the resident and in correcting resident assessments, involvement of other disciplines is dependent upon resident status and needs. The assessment must represent an accurate picture of the resident's status during the observation period of the MDS. The observation period, also known as the look-back period, is the time period over which the resident's condition or status is captured by the MDS assessment and ends at 11:59 p.m. on the day of the assessment reference date ARD. B. Aware that different items on the MDS have different observation periods. When the MDS is completed, only those occurrences during the observation period will be captured on the assessment. In other words, if it did not occur during the observation period, it is not coded on the MDS. Note: CMS is aware of situations where practitioners have potentially misdiagnosed residents with a condition for which antipsychotics are an approved use, e.g., new diagnosis of schizophrenia, which would then exclude the resident from the long-stay antipsychotic quality measure. For these situations, determine if noncompliance exists for the facility's completion of an accurate assessment. This practice may also require referrals by the facility or the survey team to state medical boards or boards of nursing. The initial comprehensive assessment provides starting point data for ongoing assessment of resident progress. Probes Section 483.20g. Based on your total review of the resident, observations, interviews, and record reviews, does each portion of the MDS assessment accurately reflect the resident's status as of the assessment reference date? Is there evidence that the health professionals who assess the resident had the skills and qualifications to conduct the assessment? For example, has the resident's nutritional status been assessed by someone who is knowledgeable in nutrition and capable of correctly assessing a resident? Tag F642. Section 483.20H Coordination. A registered nurse must conduct or coordinate each assessment with the appropriate participation of health professionals. Section 483.20I Certification. Section 483.20I1, a registered nurse must sign and certify that the assessment is completed. Section 483.20I2, each individual who completes a portion of the assessment must sign and certify the accuracy of that portion of the assessment. Section 483.20J Penalty for falsification. Section 483.20J1 under Medicare and Medicaid, an individual who willfully and knowingly certifies a material and false statement in a resident assessment is subject to a civil money penalty of not more than $1,000 for each assessment, or Roman II causes another individual to certify a material and false statement in a resident assessment is subject to a civil money penalty, or not more than $5,000 for each assessment. Section 483.20J2 Clinical disagreement does not constitute a material and false statement. Intent Section 483.20HI. Each resident's assessment will be coordinated by and certified as complete by a registered nurse, and all individuals who complete a portion of the assessment will sign and certify to the accuracy of the portion of the assessment he or she completed. Guidance Section 483.20HJ. Whether minimum data set MDS assessments are manually completed or computer-generated. Following data entry, each individual assessor is responsible for certifying the accuracy of responses relative to the resident's condition and discharge or entry status, manually completed. Forms are signed and dated by each individual assessor the day they complete their portion S of the assessment. Electronic signatures. When MDS forms are completed directly on the facility's computer, i.e., no paper form has been manually completed, then each individual assessor signs and dates a computer-generated hard copy or provides an electronic signature after they review it for accuracy of the portion S they completed. Facilities may use electronic signatures on the MDS when permitted to do so by state and local law and when this is authorized by the facility's policy. Additionally, the facility must have written policies in place to ensure proper security measures are in place to protect use of an electronic signature by anyone other than the person to which the electronic signature belongs. The policy must also ensure access to a hard copy of clinical records is made available to surveyors and others who are authorized access to clinical records by law, including the resident and or resident representative. Facilities that are not capable of maintaining the MDS signatures electronically must adhere to the current federal requirements at Section 483.20d, addressing the need for either a handwritten copy or a computer-generated form. All state licensure and state practice regulations continue to apply to certified facilities. Note, where state law or regulations are more restrictive than federal requirements, the provider needs to apply the state law standard. Backdating completion dates. Backdating completion dates is not acceptable. Note that recording the actual date of completion is not considered backdating. For example, if an MDS was completed electronically and a hard copy was printed 2 days later, writing the date the MDS was completed on the hard copy is not considered backdating. Patterns of MDS assessment and submissions. MDS information serves as the clinical basis for care planning and care delivery and provides information for Medicare and Medicaid payment systems, quality monitoring, and public reporting. MDS information as it is reported impacts a nursing home's payment rate and standing. In terms of the quality monitoring process, a willfully and knowingly provided false assessment may be indicative of payment fraud or attempts to avoid reporting negative quality measures. All information recorded within the MDS assessment must reflect the resident's status at the time of the assessment reference date ARD. A pattern within a nursing home of clinical documentation or of MDS assessment or reporting. Practices that result in higher resource utilization group RUG scores, untriggering care area. Assessments CA or unflagging quality measures QMs, where the information does not accurately reflect the resident's status, may be indicative of payment fraud or attempts to avoid reporting negative quality measures. Such practices may include, but are not limited to, a pattern or high prevalence of the following: submitting MDS assessments, including any reason asked for assessment, routine or non-routine or tracking records, where the information does not accurately reflect the resident's status as of ARD or the discharge or entry date as applicable. Submitting correction S to information in the Quality Improvement Evaluation System. Assessment submission and processing KIs, ASAP, where the corrected information does not accurately reflect the resident's status as of the original ARD or the original discharge or entry date, as applicable, or where the record it claims to correct does not appear to have been in error. Submitting significant correction assessments, where the assessment it claims to correct does not appear to have been in error. Submitting significant change in status assessments where the criteria for significant change in the resident's status do not appear to be met. Delaying or withholding MDS assessments, including any reason S for assessment. Routine or non-routine, discharge or entry tracking information, or correction S2. Information in the KAI's ASAP system. Procedures and Probes section 483.20HJ. When such patterns or practices are noticed, they should be reported by the state agency to the regional office and Medicaid Fraud Control Unit. Are the appropriate certifications in place, including the RN coordinator's certification of completion of an MDS assessment or correction request and the certification of individual assessors of the accuracy and completion of the portion S of the assessment, or tracking record completed. Tag F644. Section 483.20E Coordination. A facility must coordinate assessments with the pre-admission screening and resident review PASAR program under Medicaid in Subpart C of this part to the maximum extent practicable to avoid duplicative testing and effort. Coordination includes Section 483.20E1 incorporating the recommendations from the PASAR Level Roman II determination and the PASAR evaluation report into a residence assessment, care planning, and transitions of care. Section 483.20E2 referring all Level Roman II residents and all residents with newly evident or possible serious mental disorder, intellectual disability, or a related condition for Level Roman II resident. Review upon a significant change in status assessment. Intent Section 483.20E. To ensure that the facility coordinates with the appropriate state-designated authority to ensure that individuals with a mental disorder, intellectual disability, or a related condition receives care and services in the most integrated setting appropriate to their needs. Definitions, Section 483.20E. Intellectual Disability ID is defined in 42 CFR Section 483.102B3 as follows. An individual is considered to have intellectual disability ID if he or she has a level of retardation mild, moderate, severe, or profound described in the American Association on Intellectuals Disability Manual on Classification in Intellectual Disability, 1983, or Roman II, a related condition as defined by Section 435.1010 of this chapter. Mental disorder MD. For purposes of this section, the term mental disorder is the equivalent of mental illness, used in the definition of serious mental illness in 42 CFR. Section 483.102B1, which states, an individual is considered to have a serious mental illness, if the individual meets the following requirements on diagnosis, level of impairment, and duration of illness. Diagnosis. The individual has a major mental disorder diagnosable under the Diagnostic and Statistical Manual of Mental Disorders, 3rd edition, revised in 1987. This mental disorder is a schizophrenic, mood, paranoid, panic, or other severe anxiety disorder, somatoform disorder, personality disorder, other psychotic disorder, or another mental disorder that may lead to a chronic disability, but be not a primary diagnosis of dementia, including Alzheimer's disease or a related disorder, or a non-primary diagnosis of dementia, unless the primary diagnosis is a major mental disorder, as defined in paragraph B1IA of this section. Roman II, level of impairment. The disorder results in functional limitations in major life activities. within the past 3 to 6 months that would be appropriate for the individual's developmental stage. An individual typically has at least one of the following characteristics on a continuing or intermittent basis. A. Interpersonal functioning. The individual has serious difficulty interacting appropriately and communicating effectively with other persons, has a possible history of altercations, evictions, firing, fear of strangers, avoidance of interpersonal relationships, and social isolation. B. Concentration, persistence, and pace. The individual has serious difficulty in sustaining focused attention for a long enough period to permit the completion of tasks commonly found in work settings or in work-like structured activities occurring in school or home settings, manifests difficulties in concentration, inability to complete simple tasks within an established time period, makes frequent errors, or requires assistance in the completion of these tasks, and C. Adaptation to change. The individual has serious difficulty in adapting to typical changes in circumstances associated with work, school, family, or social interaction. Manifests agitation, exacerbated signs and symptoms associated with the illness, or withdrawal from the situation, or requires intervention by the mental health or judicial system. Roman 3. Recent treatment. The treatment history indicates that the individual has experienced at least one of the following: A. Psychiatric treatment more intensive than outpatient care more than once in the past 2 years, e.g., partial hospitalization or inpatient hospitalization, or B. Within the last 2 years, due to the mental disorder, experienced an episode of significant disruption to the normal living situation, for which supportive services were required to maintain functioning at home or in a residential treatment environment, or which resulted in intervention by housing or law enforcement officials. Persons with related conditions is defined in 42 CFR section 435.1010 as follows. Persons with related conditions means individuals who have a severe, chronic disability that meets all of the following conditions. A. It is attributable to 1. Cerebral palsy or epilepsy, or 2. Any other condition, other than a mental illness, found to be closely related to intellectual disability, because this condition results in impairment of general intellectual functioning or adaptive behavior similar to that of mentally retarded persons, and requires treatment or services similar to those required for these persons. B. It is manifested before the person reaches age 22. C. It is likely to continue indefinitely. D. It results in substantial functional limitations in 3 or more of the following areas of major life activity. 1. Self-care. 2. Understanding and use of language. 3. Learning. 4. Mobility. 5. Self-direction. 6. Capacity for independent living. Pre-admissions screening and resident review PASAR is a federal requirement to help ensure that individuals who have a mental disorder or intellectual disabilities are not inappropriately placed in nursing homes for long-term care. PASAR requires that all applicants to a Medicaid-certified nursing facility be evaluated for a serious mental disorder and or intellectual disability. 2. Be offered the most appropriate setting for their needs in the community, a nursing facility, or acute care setting, and 3. Receive the services they need in those settings. Regulations governing PASAR are found at 42 CFR section 483.100 section 483.138. Specialized services for MD or ID means the services specified by the state that exceed the services ordinarily provided by the nursing facility NF under its per diem rate. These services must be provided or arranged by the state, and could include hiring additional staff or contractors, such as qualified mental health/intellectual disability professionals. When specialized services are combined with services provided by the nursing facility, the result is a continuous and aggressive implementation of an individualized plan of care for individuals with MD or ID. The Residence Level Roman II PASAR identifies the specialized services required by the resident. Guidance Section 483.20e. With respect to the responsibilities under the pre-admission screening and resident review PASAR program, the state is responsible for conducting the screens, preparing the PASAR report, and providing or arranging the specialized services that are needed as a result of conducting the screens. The state is required to provide a copy of the PASAR report to the facility. This report must list the specialized services that the individual requires and that are the responsibility of the state to provide. All other needed services are the responsibility of facility to provide. The PASAR process requires that all applicants to Medicaid-certified nursing facilities be screened for possible serious mental disorders or intellectual disabilities and related conditions. This initial pre-screening is referred to as PASAR Level I and is completed prior to admission to a nursing facility. A negative Level I screen permits admission to proceed and ends the PASAR process unless a possible serious mental disorder or intellectual disability arises later. A positive Level 1 screen necessitates an in-depth evaluation of the individual by the state-designated authority, known as PASAR Level Roman II, which must be conducted prior to admission to a nursing facility. PASAR Level Roman II is a comprehensive evaluation by the appropriate state-designated authority and determines whether the individual has MD, ID, or a related condition, determines the appropriate setting for the individual and recommends what, if any, specialized services and or rehabilitative services the individual needs. The Level Roman II evaluation report must be used by the facility when conducting assessments of the resident, developing the care plan, and when transitions of care occur, incorporating the Level Roman II information in these processes promotes comprehensive assessment and provision of care. For residents with MD or ID, the state must provide or arrange for the provision of specialized services to all NF residents with MD or ID in accordance with Section 483.120, whose needs are such that continuous supervision, treatment, and training by qualified mental health or intellectual disability personnel is necessary. As identified in the resident's PASAR Level Roman II, specialized services provided or arranged by the state may be provided in the NF or through off-site visits arranged by the NF, while the resident lives in the facility. The facility must notify the state-designated mental health or intellectual disability authority promptly when a resident with MD or ID experiences a significant change in mental or physical status. For additional information regarding resident referral after a significant change in status, see requirements at Section 483.20K4, F646, MD/ID significant change. Notification. Any resident with newly evident or possible serious mental disorder, ID, or a related condition must be referred by the facility to the appropriate state-designated mental health or intellectual disability authority for review. Examples of individuals who may not have previously been identified by PASAR to have MD, ID, or a related condition include. Note, this is not an exhaustive list. RAI Manual 2-29. A resident who exhibits behavioral, psychiatric, or mood-related symptoms suggesting the presence of a mental disorder where dementia is not the primary diagnosis. A resident whose intellectual disability or related condition was not previously identified and evaluated through PASAR. A resident transferred, admitted, or readmitted to a NF following an inpatient psychiatric stay or equally intensive treatment. Probes Section 483.20e. For residents with a level Roman II determination and recommendations, has the facility incorporated the determination and recommendations into the resident's assessment and care plan? How does the facility identify residents with newly evident or possible serious mental disorder, ID, or a related condition? If a resident was identified with newly evident or possible serious MD, ID, or a related condition, did the facility refer the resident to the appropriate state-designated authority for review? Is there evidence that the facility provides the next care setting with the residents? PASAR level Roman II recommendations when a resident with MD or ID transitions to another care setting. Has the facility arranged for the resident to receive specialized services through off-site visits, if appropriate, to meet the resident's needs as identified in the resident's PASAR level Roman II recommendations? Tag F645. Section 483.2, 0K pre-admission screening for individuals with a mental disorder and individuals with intellectual disability. Section 483.2, 0K1, a nursing facility must not admit, on or after January 1, 1989, any new residents with I mental disorder as defined in paragraph K3I of this section, unless the state mental health authority has determined, based on an independent physical and mental evaluation performed by a person or entity other than the state mental health authority prior to admission, A, that, because of the physical and mental condition of the individual, the individual requires the level of services provided by a nursing facility, and B, if the individual requires such level of services, whether the individual requires specialized services or Roman II intellectual disability, as defined in paragraph K3 Roman II of this section, unless the state intellectual disability or developmental disability authority has determined prior to admission, A, that, because of the physical and mental condition of the individual, the individual requires the level of services provided by a nursing facility, and B, if the individual requires such level of services, whether the individual requires specialized services for intellectual disability. Section 483.2, 0K2 exceptions. For purposes of this section, I, the pre-admission screening program under paragraph K1 of this section, need not provide for determinations in the case of the readmission to a nursing facility of individual who, after being admitted to the nursing facility, was transferred for care in a hospital. Roman II, the state may choose not to apply the pre-admission screening program under paragraph K1 of this section to the admission to a nursing facility of an individual, A, who is admitted to the facility directly from a hospital after receiving acute inpatient care at the hospital, B, who requires nursing facility services for the condition for which the individual received care in the hospital, and C, whose attending physician has certified before admission to the facility that the individual is likely to require less than 30 days of nursing facility services. Section 483.2, 0K3 definition. For purposes of this section, I, an individual, is considered to have a mental disorder if the individual has a serious mental disorder defined in 483.102b1. Roman II, an individual is considered to have an intellectual disability if the individual has an intellectual disability, as defined in Section 483.102b3, or is a person with a related condition, as described in 435.1010 of this chapter. Intent Section 483.20K13. To ensure each resident in a nursing facility is screened for a mental disorder MD or intellectual disability ID prior to admission, and that individuals identified with MD or ID are evaluated and receive care and services in the most integrated setting appropriate to their needs. Definitions, Section 483.20K13. Intellectual disability ID is defined in 42 CFR Section 483.102b3 as follows. An individual is considered to have intellectual disability ID if he or she has a level of retardation mild, moderate, severe, or profound described in the American Association on Intellectuals Disability Manual on Classification in Intellectual Disability, 1983, or Roman II, a related condition, as defined by Section 435.1010 of this chapter. Mental disorder MD. For purposes of this section, the term mental disorder is the equivalent of mental illness, used in the definition of serious mental illness in 42 CFR. Section 483.102b1, which states, an individual is considered to have a serious mental illness, if the individual meets the following requirements on diagnosis, level of impairment, and duration of illness. Diagnosis. The individual has a major mental disorder diagnosable under the Diagnostic and Statistical Manual of Mental Disorders, 3rd edition, revised in 1987. This mental disorder is a schizophrenic, mood, paranoid, panic, or other severe anxiety disorder, somatoform disorder, personality disorder, other psychotic disorder, or another mental disorder that may lead to a chronic disability, but be not a primary diagnosis of dementia, including Alzheimer's disease or a related disorder, or a non-primary diagnosis of dementia, unless the primary diagnosis is a major mental disorder, as defined in paragraph B1IA of this section. Roman II, level of impairment. The disorder results in functional limitations in major life activities. Within the past 3 to 6 months, that would be appropriate for the individual's developmental stage. An individual typically has at least one of the following characteristics on a continuing or intermittent basis. A. Interpersonal functioning. The individual has serious difficulty interacting appropriately and communicating effectively with other persons, has a possible history of altercations, evictions, firing, fear of strangers, avoidance of interpersonal relationships, and social isolation. B. Concentration, persistence, and pace. The individual has serious difficulty in sustaining focused attention for a long enough period to permit the completion of tasks commonly found in work settings or in work-like structured activities occurring in school or home settings, manifests difficulties in concentration, inability to complete simple tasks within an established time period, makes frequent errors, or requires assistance in the completion of these tasks, and C. Adaptation to change. The individual has serious difficulty in adapting to typical changes in circumstances associated with work, school, family, or social interaction. Manifests agitation, exacerbated signs and symptoms associated with the illness, or withdrawal from the situation, or requires intervention by the mental health or judicial system. Roman III, recent treatment. The treatment history indicates that the individual has experienced at least one of the following: a psychiatric treatment more intensive than outpatient, care more than once in the past 2 years, e.g., partial hospitalization or inpatient hospitalization, or B, within the last 2 years, due to the mental disorder, experienced an episode of significant disruption to the normal living situation, for which supportive services were required to maintain functioning at home or in a residential treatment environment, or which resulted in intervention by housing or law enforcement officials. Persons with related conditions is defined in 42 CFR section 435.1010 as follows. Persons with related conditions means individuals who have a severe, chronic disability that meets all of the following conditions. A, it is attributable to 1, cerebral palsy or epilepsy, or 2, any other condition, other than a mental illness, found to be closely related to intellectual disability, because this condition results in impairment of general intellectual functioning or adaptive behavior similar to that of mentally retarded persons and requires treatment or services similar to those required for these persons. B, it is manifested before the person reaches age 22. C, it is likely to continue indefinitely. D, it results in substantial functional limitations in 3 or more of the following areas of major life activity. 1, self-care. 2, understanding and use of language. 3, learning. 4, mobility. 5, self-direction. 6, capacity for independent living. Pre-admission screening and resident review PASAR is a federal requirement to help ensure that individuals are not inappropriately placed in nursing homes for long-term care. PASAR requires that 1, all applicants to a Medicaid-certified nursing facility be evaluated for serious mental disorder and / or intellectual disability, 2, be offered the most appropriate setting for their needs in the community, a nursing facility or acute care setting, and 3, receive the services they need in those settings. Regulations governing PASAR are found at 42 CFR. Section 483.100, Section 483.138. Specialized services for MD or ID means the services specified by the state that exceed the services ordinarily provided by the nursing facility NF under its per diem rate. These services must be provided or arranged by the state and could include hiring additional staff or contractors, such as qualified mental health / intellectual disability professionals. When specialized services are combined with services provided by the nursing facility, the result is a continuous and aggressive implementation of an individualized plan of care for individuals with MD or ID. The Residence Level Roman II PASAR identifies the specialized services required by the resident. Rehabilitative services for MD or ID refers to those services of lesser frequency or intensity, to be implemented by all levels of nursing facility staff that come into contact with any resident who has as mental disorder or who has intellectual disability. These services are necessary, regardless of whether or not they are specified in the PASAR Level Roman II documents, and whether or not the resident requires additional services to be provided or arranged for by the state. Guidance Section 483.20 K13. The PASAR process requires that all applicants to Medicaid-certified nursing facilities be screened for possible serious mental disorders, intellectual disabilities, and related conditions. This initial screening is referred to as Level I identification of individuals with MD or ID. Section 483.128 and is completed prior to admission to a nursing facility. The purpose of the Level I pre-admission screening is to identify individuals who have or may have MD/ID or a related condition, who would then require PASAR level Roman II evaluation and determination prior to admission to the facility. A negative level I screen permits admission to proceed and ends the pre-screening process. Unless possible serious mental disorder or intellectual disability arises later. A positive level 1 screen necessitates an in-depth evaluation of the individual by the state-designated authority, known as level Roman II PASAR, which must be conducted prior to admission to the facility. Failure to pre-screen residents prior to admission to the facility may result in the failure to identify residents who have or may have MD, ID, or a related condition. A record of the pre-screening should be retained in the resident's medical record. Individuals who have or are suspected to have MD, ID, or a related condition, as indicated by a positive level 1 screen, may not be admitted to a Medicaid-certified nursing facility unless approved based on level Roman II PASAR evaluation and determination. Exceptions to this requirement are specified in Section 483.20K2 and may be exercised at the discretion of the state, as specified in the state's PASAR process. Level Roman II PASAR is a comprehensive evaluation conducted by the appropriate state designated authority that determines whether an individual has MD, ID, or a related condition. As defined above, determines the appropriate setting for the individual and recommends what, if any, specialized services and / or rehabilitative services the individual needs. The level Roman II PASAR cannot be conducted by the nursing facility. Each state Medicaid agency has specific processes for conducting level I screens and level Roman II PASAR evaluations and determinations. Exceptions to the pre-screening requirements are specified in Section 483.20K2 and may be exercised at the discretion of the state, as specified in the state's PASAR process. Facility staff and surveyors should be acquainted with their state's requirements. If the state program permits the use of the exceptions specified in Section 483.20K2, and the resident remains in the facility longer than 30 days, the facility must screen the individual using the state's level I screening process and refer any resident who has or may have MD, ID, or a related condition to the appropriate state-designated authority for level Roman II PASAR evaluation and determination. Note, under 42 CFR 483.10 6B2 Roman II, if an individual who enters a NF as an exception and exempted hospital discharge is later found to require more than 30 days of NF care, the state mental health or intellectual disability authority must conduct a level Roman II resident review within 40 calendar days of admission. The state is responsible for providing or arranging for specialized services for residents with MD or ID residing in Medicaid-certified facilities. The facility is required to provide all other care and services appropriate to the resident's condition. Therefore, if a facility has residents with MD or ID, do not survey for specialized services, but survey for all other requirements, including resident rights, quality of life, and quality of care. Procedures and Probes Section 483.20 K13. If the resident's level Roman II PASAR report indicates that he or she needs specialized services, but the resident is not receiving them, the state survey agency would notify the state designated mental health or intellectual disability authority that evaluated the resident prior to admission. NF services alone are not ordinarily of the intensity to meet the needs of residents with MD or ID. Is there evidence of level I pre-screening of residents prior to admission to the nursing facility to identify residents who have or may have MD, ID or a related condition. Who requires level Roman 2 PASAR evaluation. Are residents with a positive level IPASAR screen evaluated by the designated state authority through the level Roman 2 PASAR process and approved for admission prior to admission to the nursing facility. If pre-admission screening of residents expected to be in the facility 30 days or less is not performed in accordance with the state PASAR process, does the facility screen residents who have or may have MD, ID, or a related condition if the resident remains in the facility longer than 30 days? Are residents who have a positive screen then referred to the appropriate state authority for level Roman 2 evaluation and determination? If the resident has a MD or ID, did the state mental health or intellectual disabilities authority determine whether the residents needed the services of a nursing facility, whether the residents need specialized services for their MD or ID? Deficiency categorizations. Severity level 4 considerations. Immediate jeopardy to resident health or safety. An example of level 4, immediate jeopardy to resident health and safety, include, but is not limited to, a resident with bipolar disorder was newly admitted to the facility prior to level Roman 2 PASAR evaluation and determination. The facility's failure to ensure the level Roman 2 PASAR process was completed prior to admission resulted in the resident no longer receiving needed psychotherapy 4 times per week. The interruption in receiving needed psychotherapy services caused the resident to relapse into a depressive state, during which the resident engaged in social withdrawal and self-cutting behaviors, resulting in hospitalization of the resident. Severity level 3 considerations. Actual harm that is not immediate jeopardy. An example of level 3. Actual harm that is not immediate jeopardy includes, but is not limited to, the facility failed to ensure level 1 pre-screening of a new resident for MD/ID or a related condition prior to admission to the facility. The resident had cerebral palsy, which is a related condition. The lack of pre-screening resulted in the resident's condition not being identified prior to admission and the resident not being evaluated. Through the level Roman 2 PASAR process, the resident did not receive the specialized rehabilitation services she needed, which resulted in a decline in her function. Severity level 2 considerations. No actual harm with potential for more than minimal harm that is not immediate jeopardy. An example of level 2, no actual harm with potential for more than minimal harm that is not immediate jeopardy includes, but is not limited to, the facility failed to ensure level 1 pre-screening of new residents for MD/ID or a related condition prior to admission to the facility, while the residents did not have MD/ID or a related condition. The facility admitted the residents without knowing if the residents had one of these conditions. The failure to determine whether the residents had MD/ID or a related condition had the potential to cause more than minimal harm to new and/or current residents. Severity level 1, no actual harm with potential for minimal harm. Failure to ensure residents are pre-screened for MD/ID or a related condition prior to admission to the facility could prevent the resident from attaining or maintaining his or her highest practicable level or result in a decline in the resident's physical, mental, or psychosocial well-being. Therefore, severity level 1 does not apply for this regulatory requirement. Tag F646. Section 483.2. 0K4 A nursing facility must notify the state mental health authority, or state intellectual disability authority, as applicable, promptly after a significant change in the mental or physical condition of a resident who has mental illness or intellectual disability. For resident review, Intent Section 483.20K4. To ensure that individuals with a mental disorder or intellectual disabilities continue to receive the care and services they need in the most appropriate setting when a significant change in their status occurs. Definitions, Section 483.20K4. Pre-admissions screening and resident review PASAR is a federal requirement to help ensure that individuals who have a mental disorder or intellectual disabilities are not inappropriately placed in nursing homes for long-term care. PASAR requires that all applicants to a Medicaid-certified nursing facility be evaluated for a serious mental disorder and or intellectual disability, 2, be offered the most appropriate setting for their needs in the community, a nursing facility, or acute care setting, and 3, receive the services they need in those settings. Regulations governing PASAR are found at 42 CFR Section 483.100 to 138. Significant change is a major decline or improvement in a resident's status that one will not normally resolve itself without intervention by staff or by implementing standard disease-related clinical interventions. The decline is not considered self-limiting. Note, self-limiting is when the condition will normally resolve itself without further intervention or by staff implementing standard clinical interventions to resolve the condition. 2, impacts more than one area of the resident's health status, and 3, requires interdisciplinary review and or revision of the care plan. This does not change the facility's requirement to immediately consult with a resident's physician of changes as required under 42 CFR Section 483.10I14, F635. Significant Change in Status Assessment, SCSA, is a comprehensive assessment for a resident that must be completed when the interdisciplinary team IT has determined that a resident meets the significant change guidelines for either improvement or decline. Guidance Section 483.20K4. As part of the pre-admission screening and resident review PASAR process, the facility is required to notify the appropriate state mental health authority or state intellectual disability authority when a resident with a mental disorder MD or intellectual disability ID has a significant change in their physical or mental condition. The nursing facility must notify the state mental health SMH/ID authority of significant changes in residents with MD or ID independent of the findings of the SCSA. PASAR Level Roman II is to function as an independent assessment process for this population with special needs. In parallel with the facility's assessment process, nursing facilities should know their state's PASAR policy on referral to the SMH/ID authority so that these authorities may exercise their expert judgment about when a Level Roman II evaluation is needed. Referral to the SMH/ID authority should be made as soon as the criteria indicative of a significant change are evident. The facility should not wait until the SCSA is complete. Facilities should look to their state PASAR program requirements for specific procedures. PASAR contact information for the SMH/ID authorities and the state Medicaid agency is available at http://www.pasarsis.org/resources/personnel/PASAR state lead contact information. Referral for Level Roman II resident review evaluation is required for individuals previously identified by PASAR to have a mental disorder, intellectual disability, or a related condition who experience a significant change. Examples of such changes include, but are not limited to, a resident who demonstrates increased behavioral, psychiatric, or mood-related symptoms, A resident with behavioral, psychiatric, or mood-related symptoms that have not responded to ongoing treatment. A resident who experiences an improved medical condition, such that the resident's plan of care or placement recommendations may require modifications. A resident whose significant change is physical, but has behavioral, psychiatric, or mood-related symptoms or cognitive abilities that may influence adjustment to an altered pattern of daily living. A resident whose condition or treatment is or will be significantly different than described in the resident's most recent PASAR level Roman II evaluation and determination. Note that a referral for a possible new level Roman II PASAR evaluation is required whenever such a disparity is discovered, whether or not associated with a SCSA. Requirements for the completing a SCSA are found at section 483.20 B2 Roman II, F637, Comprehensive Assessment after Significant Change. Probes section 483.20 K4. When a significant change in status was identified in a resident with a mental disorder or intellectual disability, was the appropriate state mental health or intellectual disability authority promptly notified? Does the facility have a process in place to notify the appropriate state mental health or intellectual disability authority when a resident with a level Roman II PASAR has a significant change in his or her mental or physical status? This concludes the reading of Appendix PP, Regulation Section 483.20, tags F635 through F646.